Hello, my name is Janet and I'm publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision and continuing professional development. This year, medicine celebrates its 50th anniversary. In honour of this, we've put together a collection of podcasts recorded by the journal's chairman, Albert Ferro. We hope you enjoy them. If you want to find out more about medicine, including how to subscribe, please visit www.medicinejournal.co.uk.
Welcome to the latest podcast in the series for the 50th anniversary of the Medicine Journal. My name's Albert Ferro. I'm a clinical pharmacologist based at King's College London, and I chair the Editorial Board for Medicine. And I'm very pleased to welcome with me today Professor Sir Munir Pirmohamed from Liverpool. He's a fellow clinical pharmacologist of mine, which is good in itself, but he has a lot of other responsibilities as well. He's the David Weatherall Chair of Medicine. He is the NHS Chair of Pharmacogenetics in Liverpool University, and he also directs the Centre for Drug Safety Science and the Wolfson Centre for Personalised Medicine. So a lot that you carry on your shoulders, Munir. And I know you've had a long-standing interest in adverse drug events and adverse drug reactions and safety in prescribing and personalized prescribing. And today we're going to be concentrating on pharmacogenetics and pharmacogenomics, which is very much geared towards as an integral part of personalized medicine. So I won't go through your whole career, Munir, because that would probably take up all of our time. But perhaps you could maybe start by telling us a little bit about how you got into the genetics genomics field, and particularly related to clinical pharmacology.
Sure. So thanks very much, Albert. So when I was a medical student, I became very interested in pharmacology and talked to various people who were doing pharmacology. And as I qualified in medicine and then did my junior training, I retained that interest in clinical pharmacology. So I decided that I wanted to pursue a career in that, but I was also interested in molecular biology. So what I did was to undertake a PhD and got in through an MRC fellowship, so whereby I could combine the molecular work together with the pharmacology, and that's how I did my PhD. That's how I got interested in the clinical pharmacology, variation in drug safety, variation in drug efficacy, and then how we can actually use genetics to be able to improve that.
And the rest is history, as they say. Now, when I think about the application of genetic science to prescribing clinical pharmacology, I think of it as a very recent phenomenon, something that's cropped up in the last decade or two. But I know from my conversations with you previously that the history goes back a lot further than that. Would you perhaps tell us a little bit about the history?
Yeah, so if you can trace the history of pharmacogenetics right back to the time of Pythagoras. Pythagoras basically explained that some people get seriously ill after congesting fava beans, particularly if they live in certain Mediterranean countries. And fava beans causes a condition called favism, which is associated with red blood cell hemolysis, hemoglobinuria, and acute renal failure, and can be fatal in individuals. At that time, obviously, Pythagoras didn't know that this was related to glucose-6-phosphate dehydrogenase deficiency. We now know that is the most common human enzyme deficiency in the world. It's not only relevant to fava beans, but it's also relevant to many drugs, including antimalarials such as primaquine, the new antimalarial tafenoquine, some anti-cancer drugs, as well as some antibiotics such as dapsone and sulfonamides. Mm-hmm. So that was the first time, I think, that pharmacogenetics was described. But the term pharmacogenetics was coined by a German pharmacologist called Friedrich Vogel in 1957. And then, it's progressed from that in terms of how we've practiced pharmacogenetics, going from the kind of single gene work, which then when PCR was invented, we started using PCR for pharmacogenomic testing. And then finally, through the sort of after the completion of the Human Genome Project, what happened was there's been a massive increase in numbers of pharmacogenomics papers in PubMed, and largely because the technology has become much more widely available, the evidence and the information required for pharmacogenomic research has become more widely available. And so more and more people have become interested, to where we are now, where I think at the moment we are at a turning point where to say that really pharmacogenomics needs to be implemented into healthcare practice.
And so things have really kind of taken off very recently. Can I maybe just sort of ask you to explain for the listeners and viewers just a little bit about terminology? And some people may be a bit confused about the difference between genetics and genomics, pharmacogenetics and pharmacogenomics. Could you just maybe just expand, what those two terms mean?
Yeah, so pharmacogenetics was the term which was coined by Friedrich Vogel in 1957. And that's largely because at that time we could only look at single genes, and we were really focused on that. And in fact, we didn't have the technology to look at more than one gene or more than one variant until much earlier part of the century. But, with the sort of completion of the Human Genome Project, we suddenly got the ability to be able to look at the whole genome. So in 1997, the term pharmacogenomics was coined, allowing us to be able to think about the whole genome, not just one gene, but also RNA as well, because that's part of pharmacogenomics. So really, the term now pharmacogenomics is perhaps more appropriate because we have the technology to be able to look at the whole genome rather than individual genes, but obviously people still look at individual genes as well. So, but I think the terms are used interchangeably, and I think most people will accept whichever term you use, really.
And that's an interesting thing that you bring up, the fact that we now are much more able to look at the whole genome rather than single genes. And perhaps we could take an individual example, which I guess is quite dear to my heart, because I'm a cardiovascular physician and researcher, and clopidogrel is a drug that's quite widely used in cardiology. And we know that, of course, in the case of clopidogrel, a large number of the population are poor metabolizers due to variations in CYP2C19, and we can test that. But I guess now we can do a lot more than that. We can test the whole genome. And my question, I guess, is twofold, really. First of all, in that kind of scenario, should we be routinely testing those patients for CYP2C19? And secondly, if we're going to do that, should we actually be doing the whole genome anyway? Because, that's going to give us a lot more information, not just about this drug, but about other drugs that they may be prescribed in the future.
Yeah, so those are important issues. So we produced a report called Personalized Prescribing. That report was joint between the Royal College of Physicians of London and the British Pharmacological Society. I chaired the working party. And for your listeners, the Royal College of Physicians represents 26 specialties, that are important in terms of different areas of clinical practice. And in that particular report, we basically provided the evidence saying that it was now time to implement pharmacogenomics into the NHS. Although it is focused on the National Health Service in the UK, many of the things we've said in there are important for any healthcare system in the world. And really, the evidence base is there, the technologies are there, and there we need to be able to improve the way we use medicines in patients and not ignore that that sort of genetic evidence that is eminently available if we use the technologies that are available to us. So cytochrome P452C19 and clopidogrel certainly fits within that category that we should be testing for people for 2C19 when we prescribe clopidogrel, particularly for stent thrombosis, where there's very good evidence to prevent stent thrombosis, and also now increasing evidence for people who have transient ischemic attacks and strokes. Because, if you're going to give somebody clopidogrel after they've had a transient ischemic attack, if they're a poor metabolizer, they do not transform the clopidogrel into this active metabolite, and therefore they don't get the benefit, and they're at higher risk of stroke. And that's been shown now in several studies, and it's been shown to be cost effective to be able to really genotype for that as well. So that's, looking at just clopidogrel and 2C19. But what we argued in personalized prescribing is that we should do panel testing for pharmacogenomics. What that means is that when somebody comes in, let's say being prescribed clopidogrel, you would do the test for clopidogrel, but you'd also test for a variety of other pharmacogenes. And you'd get the result you want for clopidogrel right there and then, but you'd store the other data, other pharmacogenomic tests on the electronic health record. So as the patient gets older and they require another drug which has pharmacogenomic guidance, that data is already available for you. It's just having renal function tests or liver function tests available for you. So you can decide on how you prescribe based on that data. So what we suggested is that we're going from a reactive strategy that you do a test when you need it to a preemptive strategy so that you have the test available in your electronic health record. We felt that this would be, at this stage, the most cost-effective way of being able to put pharmacogenomics into clinical practice and implementation. However, as we progress in the future, as technologies become cheaper, sequencing becomes cheaper, it is possible that almost everybody will have a pharmacogenomics panel done or sequencing done very early in their life. And there are already pilots going on or planned in the UK. The pilots are already going on in other parts of the world where you can do whole genome sequencing in newborns. And clearly, when you do whole genome sequencing in the 22,000 genes or so that are in the human genome, there will be many pharmacogenes in there, so we'll have that data available, which needs to be made available to the healthcare system in some way. But the way you do that, what are the ethical issues associated with that, needs to be looked at, and we need that conversation, not only amongst ourselves, but the conversation with the patients and the public in terms of what they want.
So we're really sort of looking at a future where babies might have their blood taken and the genome sequenced, for future use at some point.
That's right. Yeah. And then, as you know, we already do a heel prick test at the moment, and we use mass spectrometry to test for certain rare inborn errors, of disease. But that cost of that mass spectrometry test is probably now greater than the cost of whole human genome sequencing.
Interesting. Thank you, Munir. You've given us a couple of examples there where pharmacogenomics has really sort of made it, and we've talked about clopidogrel, and perhaps just give us a little bit of a flavour of one or two other instances where in recent times it is now known that having that genetic information makes a real difference to someone's healthcare.
One of the best examples is abacavir. And abacavir hypersensitivity. Abacavir is an antiretroviral, anti-HIV drug used in combination with other HIV drugs. Very effective, but unfortunately, when it was developed, it was identified that 5% of individuals got a hypersensitivity reaction. What I mean by that is that they get a skin rash, breathlessness, and gastrointestinal manifestations such as diarrhea. And when you re-challenge them with the drug, you can get such a severe reaction that some patients died with that hypersensitivity reaction. So work which was undertaken in Australia, in the United States, and then by ourselves was able to show a very strong association with the HLA allele. HLA stands for human leukocyte antigen, and it resides on the short arm of chromosome 6. And the HLA region in the human genome is the most polymorphic region of the human genome. And the particular HLA which was identified, which was associated with abacavir, is called HLA B star 5701. Bit of a mouthful, but hopefully you can remember that. And so when we did the study in the UK, we asked the question whether it would be cost effective to genotype for HLA B5701. And we showed through cost-effectiveness model that it would be cost-effective in most instances, and actually be cost-dominant in some instances as well, where you used a different drug, which was relatively cheap. And so that data was used by HIV clinics to convince the NHS to be able to implement pharmacogenomic testing in the NHS. So we published in 2004. By 2006, every HIV clinic in this country was using HLA-B57.1 genotyping before they put patients on abacavir. And the net effect of that has been dramatic. The incidence of abacavir hypersensitivity before testing was about 5%. It's now less than 1%. I haven't seen a case of abacavir hypersensitivity for almost a decade now because of the success of the test. So that tells you that you can actually make a difference in terms of how it works. But there are other examples where there is good evidence, but maybe limited usage. And the other example I want to give is of warfarin. Warfarin is an anticoagulant, but it's quite difficult to know what dose of warfarin to put somebody on. It could be 0.5 milligrams or 20 milligrams. There's a 40-fold variation in dose requirement. And work which has been undertaken by us, but by very many other people, has shown that there are two major genes which are important for warfarin dose determination. One is cytochrome P452C9, which is the enzyme that metabolizes warfarin, and the other is vitamin K epoxylates complex, which is the enzyme inhibited by warfarin. And so work which we've undertaken, plus others have undertaken, is that if you take cytochrome P452C9, if you take vitamin K epoxylates complex genetics, and then you add age, body mass index, and your drug-drug interactions in there, you can actually predict about 60% of the dose variation in warfarin mean weekly dose. So we were able to develop the algorithm, and then we were able to show in a randomized controlled trial, which was published in the New England Journal of Medicine, that algorithm was able to improve anticoagulation control with warfarin compared to standard of care. And the difference we found between the randomized arm, the sort of test arm versus the control arm, was about 8%. Now, 8% from the literature in terms of time in therapeutic range has been shown to have a marked clinical effect in terms of reduction in strokes, reduction in thrombosis, reduction in bleeding events. So we did that, and what we did in that, we used a point of care test whereby we just took a small blood sample, put it in the machine, the results came out in 2 hours, and we were able to then put the results onto a web-based algorithm which told us what the dose should be in the patient based on the genetics. We then refined that test to make it into a 45-minute test, and we then put it into a clinic, in several clinics in the Northwest, where nurses and pharmacists did the testing without a protocol, and they just did the testing after training, and they were able to show the same effect in real-world practice.
Excellent.
So we basically confirmed it in a randomized control trial, and then also in real-world practice as well, that genetic testing actually is better determining what your dose should be, and therefore improves your anticoagulation control. But what happened next was outside our control, was that those new anticoagulants came into being, which was the direct oral anticoagulants. And then the pandemic happened, where there was a national guidance that we should switch people from warfarin to DOACs, because DOACs don't need the monitoring, whereas warfarin does. We wanted to reduce the interactions with patients to reduce the transmission of the virus. So lots of people moved away from warfarin onto DOACs, and therefore, we don't really the sort of number of people on warfarin has gone down over the last few years. There are still some people on warfarin who need the test, but overall, the number of people on warfarin are much less, and we now use DOACs instead of warfarin. So although you may have a test, you may have identified the pharmacogenomic variants, you may have developed evidence base, including a randomized control trial, it doesn't necessarily mean that it will be widely used, because new drugs may come along which may displace the old drug.
And I suppose in this particular case, we're talking about newer drugs that have less variation from person to person, so that the need for that testing has been supplanted.
Allegedly. Let's say we won't get to the debate of the various DOACs if you look at the plasma concentration.
This brings us on to something you talked about earlier on, Munir, and that is cost. And as we know, the cost of sequencing the whole human genome used to be very high, and now it's a lot less. And you'll know much better than me what the cost is now. So it is much cheaper. And so it's a more realistic proposition to do this kind of testing on a widespread basis. But we know also that the NHS is very cash starved and has difficulty funding a lot of other worthwhile things. So my question to you is, how likely do you think it is that pharmacogenomic testing will be taken on by the NHS in a more widespread fashion?
So our report, Personalised Prescribing, provides the evidence base for why the sort of NHS should take up pharmacogenomic testing. We have a lot of evidence now which shows that drugs don't work in every patient that we give them. So we have a trial and error approach whereby we give one drug, if it doesn't work, we give a second drug, etc. And a significant number of people in this country develop adverse reactions which lead to hospital admission. A recent study we undertook, which is one particularly in the multi-morbid populations, showed that 16.5% of all admissions to our hospitals are due to adverse drug reactions. The cost to NHS England, just England, was £2.1 billion a year. So that's a huge cost. So obviously with any innovation, the NHS has to look at evidence base. The NHS has to look at what the cost outlay is going to be, and NHS also has to look at what the cost effectiveness is. And so if you look at the evidence base has been growing, that this genetic testing is important and will be able to improve patient outcomes. When you look at the cost effectiveness, when you look at individual tests, and when you look at the cost effectiveness of those, again, people have shown that the individual tests can also be cost effective, such as cytochrome P452C19 and clopidogrel, HLA-B5701, and abacavir. But we've also shown recently that if you do a panel-based test, that is actually quite highly cost-effective, actually cost-dominant in many cases. And there's increasing evidence now in the literature showing that pharmacogenomic testing is cost-effective and sometimes actually cost-dominant. That's also sorted out. But obviously, if you're going to introduce a new innovation into any healthcare system, there will be cost outlay at the beginning, because you have to train people, you'll have to have the machinery, etc., to be able to do the testing. And that cost outlay obviously is a cost initially, but obviously over the long term, there's cost savings and so on, and the cost effectiveness comes into being. So my feeling is that the evidence base is there, and obviously the NHS has to make a decision whether they feel that this is the right time to be able to implement pharmacogenomics into clinical practice. Clearly, there are a lot of innovations that come through. A lot of new drugs come through. The drugs which come through, which cost £1 million, for treat one patient. And the NHS has been very, very good at introducing those. Here, we're looking at things which are costing, maybe for a test will be less than £100. And you only need to do a test once. And the whole genome sequence now, the latest cost, which have been advertised, is only about $200, right? Which is like not having any lattes for 3 weeks or 3 months or something like that, right? So
depends how many lattes you have, I think.
Yeah, exactly. So if you have one latte a day, you're going to be spending £200 in over 3 months or so, given the price of lattes nowadays.
Yeah, no, that's certainly true.
So basically, it's not actually that expensive to do that. I guess the other issue is, having the skills and knowledge to be able to make sure to interpret the data correctly and make the right clinical decision. And obviously that requires the training, and that training is also a cost issue as well. And obviously I think that, we have to be able to train our workforce, make them much more skilled in many different areas. And this is one of those areas. And the way I think about it is that pharmacogenomics and genomics is very much an evolution in the way we practice medicine. It's not a revolution. We, in the sort of early part of this last century, we didn't have many drugs. And we started using things such as arsenic and things like that. And we've evolved, into better drugs with better safety, efficacy, etc. We've started using liver, renal function testing, etc. And now we've got genetic testing. So it's an evolution of the way we practice drug medicine and so on. And my feeling is that we now need to move away from genetic exceptionalism to actually incorporate this into our clinical practice. I think a genetic test, which allows you to be able to decide which drug to give, what dose to give, is the same as using a liver or renal function test.
And I guess one of the other challenges is around making sure that the information follows the patient and it's incorporated into their health record. So that's something that is going to be another challenge, isn't it?
That's right. Yeah, absolutely. So, that is a challenge, particularly given that there are many different systems, particularly in secondary care in this country and in many other parts of the world as well. In the UK, in primary care, there are two main systems, so that makes it easier. But obviously, what we don't want to do is to have somebody have a pharmacogenomic test done in London, but when they're traveling to, let's say, Newcastle, and they unfortunately have to seek medical attention in Newcastle, we want the doctors in Newcastle to be able to get access to the pharmacogenomic test rather than, treat them blind without the pharmacogenomic test. And so we need to make sure that our health systems are interoperable so that, you can actually access the relevant test results when you need to, wherever you are in this country. But another possibility is that the patient carries their own data on their phone. I think over 20 million people have downloaded the NHS app. And the NHS app might be the best vehicle in the future that you carry your own genomics information. And so that whenever you see any healthcare professional anywhere in the country, perhaps also in the world, that it provides you with that genomics data that you can use to be able to make sure that you get the right drug at the right dose.
We've talked a lot about the application of this in terms of prescribing and the use by health professionals and so on. And I maybe want to finish this podcast by talking about something else, which I know is quite close to your heart, and it's the area of where it might be applied to drug discovery and development. Could you tell us a little bit about how you think pharmacogenomics could be used in that arena?
Yeah, so I sort of like to use a broader definition of pharmacogenomics, which is not only in terms of identifying what the genetic factors are in individuals and then determining what drug may be best for them, but also using pharmacogenomics in terms of drug discovery as well and drug development, because we can use that pharmacogenomic information to identify drug targets and also in terms of safety as well, in terms of reducing risk and hazard from medicines. So and that's increasingly being used actually. And so if you look at data that's been published now from the pharmaceutical industry, it shows that if you can identify a genomically defined target, then your chances of actually developing a successful drug which gets to market is twofold higher. And if you consider that twofold may not seem very much, but if you consider that it takes $1.5 billion to develop a drug, if you can actually increase your success rate by twofold, that's a huge saving in terms of that drug development process. So I think that's important, and a typical example of how pharmacogenomics in this broader definition is being used for drug discovery and drug development is with PCSK9. This is where we now have antibodies which are able to interact with PCSK9 and inhibit PCSK9 and reduce the cholesterol. And that is important. And highlights how genetic information was allowed us to be able to identify a drug target and then lead to development of a drug which not only reduces cholesterol, but has been shown to have reduced cardiovascular outcomes as well, adverse cardiovascular outcomes. So that's one example. The other example is in terms of drug safety. So, we have a lot of data out there in terms of epidemiology, which suggests to us that actually there might be a potential adverse effect, but this data is confounded and we can never be sure whether there is a true causal association between a drug and adverse effect. So let me give you an example of statins and cataract. So statins have been thought to cause cataract, particularly over long-term use. But if you look at the epidemiological studies, some of them have shown an association, some of them have not shown an association. And when somebody did a meta-analysis of the observational studies, they found an odds ratio of 1.12, so 12% increase, right? But that could be due to chance because there's, different patients were involved in the different studies, different background of diabetes. So it could be due to confounding factors. However, somebody's done a recent study where they looked at UK Biobank and they identified people who had variation in HMG-CoA reductase, which is the enzyme which is inhibited by statins. And from that genetic score, they were able to show some people had low activity of HMG-CoA reductase, while other people had high activity of HMG-CoA reductase. And when they looked at people with the low activity of HMG-CoA reductase, they showed that those individuals had a higher risk of cataracts and cataract surgery. So that provides some biological plausibility that actually inhibiting HMG-CoA reductase increases the risk of cataracts, which is exactly what statins do. But they were also able to show that actually, if you look at PCSK9 and the variation PCSK9, that did not lead to cataract formation in UK Biobank. And so we can say that actually individuals who go on PCSK9 are less likely to develop cataracts compared to people on statins. But I think we should put a context on that. The benefits of statins far outweigh the risk of cataracts. Certainly, so in most cases, cataracts don't occur. But in those individuals where there's a family history of cataracts or there's an increased risk of cataracts for whatever reason, then the physician could actually make a decision saying, well, actually, this may be a person I don't need to use statins on, I need to use another anti-lipid lowering therapy, such as Zetamib, for example.
I think the possibilities seem endless. And it will really be interesting to see where we are in 10 years' time, both in terms of impact on prescribing, but also a prediction of adverse events and so on. Munir, I think our time is up. This has been a fascinating discussion, and I just want to say thank you once again for your time.
Thank you.